For health IT projects, success depends on more than just scope, schedule, and budget. If you don't understand how clinical care is actually delivered, it can be challenging to keep SMEs engaged, to make testing and training meaningful, and to achieve a good adoption rate after go live. Clinicians and front-end staff always think in terms of workflows, and understanding them as a PM can help you lead diverse stakeholder groups and have discussions that remain patient-centered instead of system-centered. At a very basic level, patient workflows follow a similar core path. The patient is identified and then registered, admitted, or transferred to the care area. Their condition is assessed. Testing, treatment, and care plans are developed. Clinicians administer care according to those plans. And then once all of the patient goals are met, the patient is discharged or transferred to another area. Project managers don't need to be clinicians, but they do need to understand this general flow and to use it as an anchor for project conversations. Because clinicians, administrators, and IT staff all think differently, and the patient's care path is a common thread that they can all relate to. It reduces confusion and keeps conversations focused. Now, that basic care path is consistent, but as I mentioned, it's very high level, so there are some differences in different care settings. Emergency, surgical, inpatient, and outpatient workflows all look slightly different, and IT systems need to support those differences. Anchoring conversations in the patient journey can help us uncover where those differences are early on in our project initiatives. For example, let's say you're leading a project to implement a new clinical system that is going to be used in a variety of departments. You're going to want to ask SMEs if there are any variations you need to be aware of. Asking this question broadly will bring up a lot of feedback that's difficult to organize, but anchoring things in that basic care path will help to keep things structured and more meaningful. You can start with the first piece, which is identification, and ask if there are any areas that do anything different with respect to identifying a patient. Chances are pretty high the first group that's going to pipe up is going to be the emergency department or a group that receives patients from the emergency department, and they're going to let you know that sometimes a patient can't be positively identified before they receive care. As a PM, hearing this lets you know that the team is going to need to figure out how to register patients who can't be positively identified, what happens in the system from both a functionality and workflow perspective when their identification can be confirmed, because it would be mid-stay, or perhaps when they're discharged, and who needs to be involved in signing off on the workflow variations that are going to be put in place to accommodate this type of variation. Another area that understanding clinical workflows and that basic care path can be helpful is in risk management. Handoffs and transitions tend to be a high-risk area that we need to pay attention to. And if the PM is aware of that basic care journey, they'd be more familiar with where some of those handoffs might occur. For example, medication reconciliation when a patient is transferring from the emergency department to the inpatient unit is going to involve ED staff, the inpatient staff, as well as the pharmacy. So knowing this, the PM can flag this step or these areas as higher risk in their project plan and something they want to pay closer attention to. They can ask SMEs if there's additional safeguards that need to be put in place, or if there's some escalation processes that they need to be aware of in this particular area, and they can ensure that the training and downtime documentation covers these transition points well. Understanding these workflows gives the PM context to ask better questions when they're doing their risk planning and to tie things back to real patient safety concerns. Another piece that we can look at is testing, which is going to be more effective if it's structured around real workflows. For example, let's say we're going to test pre-op status boards and whether or not some of the icons are changing based on results that are coming in or activities that are being done by nursing. Now, if you're a PM who's not familiar with the care path, you might think, great, let's just put the QA testers in a room, make sure we have a test environment to work in, and that we have someone to log our defects. If you're a PM that understands clinical workflows, one of the pieces that you're going to know that you need to include and resources that you'll need to account for are the people who have to identify and register the test patients into the area that's going to get them onto the status board. So the test script is probably going to start at the status board, but there's a whole bunch of pre-work that will need to happen in your test environment to make sure that takes place. And if you understand the workflows, you can account for that easily. If you don't, you might not be aware that that has to be done. And on the day of testing, everyone will get in the room, and the first question that someone will ask is, where are my patients? And you'll be scrambling on a Teams chat to find someone from registration to get those patients registered in the right area. PMs don't need to be clinical experts, and they don't need to understand every single workflow in every single area of a healthcare organization. But they do need to understand enough about it to help in planning, decision-making, risk management, testing, adoption, and facilitation. It builds alignment with team members, helps reduce the number of missed details that you have along the way, builds trust with the stakeholders that you're working with, and keeps your projects focused on what matters most: safe and effective patient care.